Welcome to It Depends, the podcast for therapists by therapists. I'm your host, Dr. Joy Zelikovsky, and this is the place where nuance lives. Each week, I sit down with a fellow mental health professional to talk about the lessons we wish we knew when we started, the clinical moments that changed us, and the wisdom we carry now. This isn't a how-to, it's not a highlight reel, it's the honest, messy, meaningful conversations we don't always get to have. Whether you're just starting out or decades into the work, you'll find real talk, shared humanity, and space for the questions we all come back to. What's the right answer? Well, it depends. Let's get into it. Dr. Amy Boyers is a clinical psychologist and one of the co-founders of Galen Hope, a mental health and eating disorder treatment center for teens and adults in Coral Gables, Florida. With a private practice in Miami since 2001, she specializes in women's health, eating disorders, anxiety, and behavioral medicine. Dr. Boyers completed her doctoral training at the University of Miami and has held clinical roles at the Renfrew Center and University of Miami. She is adjunct faculty at the University of Miami and has published and presented nationally on topics including trauma, stress, and adolescent development. I am so excited and honored to welcome Dr. Boyers to the It Depends podcast.
All right. So, hi, Amy. Welcome.
Thank you so much for having me. Honored to be here. Numero uno. I'm very excited.
I'm so excited that you're here and that you're numero uno. And the dogs that I just mentioned have now migrated to the couch.
They heard about this and they're like, I got to be a part of it.
They have so much to offer, mostly chaos, but they want to contribute.
They're like, now's the perfect time to have a wrestling match.
Right. It is. Yeah. They're right next to me off camera, like just waiting.
Of course they are.
So normally with these things, I would have a little bio and introduction, but the whole point is to get you to know you and your story. So I was going to save the bio for you, and I'd love to hear just a little bit about what you do, what therapy and services are to you, and then how'd you get into this?
Sure. So I am Dr. Amy Boyers. I'm a clinical psychologist in Miami, Florida. I did my graduate training at University of Miami, where I did my master's and my PhD, and I have lived here ever since. I'm actually also from Miami, interestingly enough. I never thought that I would wind up back here, but here I am. And I did actually 2 postdocs. I did one at the University of Miami on a breast cancer grant through the Department of Defense. And then I did a secondary postdoc with the Renfrew Center.
So what I'm hearing is you're a glutton for punishment.
Well, I pretty quickly realized, even though I did my master's and PhD in a fairly academically oriented program, as soon as I started doing clinical work, I knew that for me, the research was really just a means to an end for me. I had done a lot of research as an undergrad as well. I actually worked with Martin Seligman in undergrad. Yeah.
You're just a rock star in every way.
In his lab as an undergraduate research assistant, I had a friend who was working for him. He's also a psychologist in New York now. And he was like, you need to do this. You need to get your research experience in. I was a freshman and he's like, you need to start. So I was fortunate that I had someone that pointed me in the right direction early. And I worked on various research projects with him. And then actually after college, I just decided to get a fun job so that I could live in New York City. So I worked in publishing for a year, and then I was like, okay, it's time to focus on grad school again. And then I got a job as a research assistant at Memorial Sloan Kettering in New York City doing cancer research. And that actually turned out to be what was really just me getting a job randomly so I could stay living in New York City. And it was like, psychology jobs are fairly limited when you only have a bachelor's degree.
Yeah.
And I wound up getting this job working with Dr. Sharon Manny on couples with cancer. And so that wound up sort of leading me towards doing my PhD in clinical health psychology at University of Miami. And so, everything kind of happens for a reason. One thing leads to another. And then when I went to do my postdoc, the Renfrew Center was opening up a step-down facility in Coral Gables. And that's where I lived. So I was able to take that job. And I had always been interested in working with eating disorders, and I wasn't exactly sure how I was going to get into that because I was doing clinical health psychology and my program had no connections at that time with anything eating disorder related. All I knew was I was extremely interested in it. It was something that I was drawn to. Intellectually, and even though it wasn't an experience I had personally. And then this door opened with Renfrew, and then I wound up really just renting an office. It wasn't that I joined a practice, but I joined a space with two older psychologists who treated eating disorders. They were some of the first people to treat eating disorders in the country. Dr. Roy Ehrlichman's one of the founders of IADEP. And I wound up in his office, and he and I and his brother Elliot would meet every single week and discuss cases and have lunch together. And they were analytically trained. I was trained really very cognitive behaviorally. And so that wound up having a huge influence for me in terms of meeting people in the eating disorder community. I started the Miami IADEP chapter because basically Roy's like, will you do it? Will you start it? And I said, sure. And getting supervision from a psychoanalytic perspective. And so that became, I think a really important experience for me as well in terms of really integrating and having as you were talking about, getting training after you graduate, after you do all your supervision for licensure and all that stuff, having mentors in your life that you interact with, whether it's working in an agency or in a treatment center or working in a group practice where you have access to more experienced clinicians. And, if you treat eating disorders, you're going to wind up with sometimes some very scary, complicated situations that fall in your lap, that there is nothing that you will ever learn in school that will prepare you for that. So you have to have solid training and instincts to be able to know how to navigate that. And so having the two of them available to me like that on a daily basis was enormously helpful.
What a beautiful stroke of luck that you ended up with them, because that is so incredibly important and shaping in your career early on.
Yes. Yeah. I was fortunate to have found myself in that situation more than once. And I think for me, a lot of it is, it's not because I'm so special. It's because I saw doors opening and I walked through them. And so to be at a school with someone like Martin Seligman, and there's lots of universities with lots of people who were doing very impressive research, and just recognizing there's an opportunity here and I'm going to throw my hat in the ring, right? Lots of kids applied. I did get the position, but lots of kids applied. But I think that is something that sometimes I think now is a little bit more challenging for people. A lot of applying for things is anonymous. You have to just submit something to an email address or fill out an application. And I think a lot of people are daunted by that. And so being willing to go up to a professor that you're working with and saying, I think what you're doing is really interesting and I really want to learn more. I see a lot of college-age kids really afraid to do that. And that's taking that first step towards what could be the rest of your career.
And as you talk about that and thinking about some of the experiences that I've had in my career too, that have been very similar, where I just randomly emailed somebody and said, hey, I'm interested if this is an opportunity, or do you have anything? Or I know we both are connected to Wendy, and I think I met Wendy that way too. I walked up to her and said, "Hey, I would like to know you because you have really cool stuff to say." And then she
Mhm.
introduced me to you. So
Right.
it's funny how important those little things are that we don't think about.
That openness to experience, right? And I think that is obviously a core feature of being a clinician, being open to experience. And your clients, when they come in the room, are going to have often very different perspectives on things than you, very different life experiences with you than you. And so, can you sit in that space of just being open and let's see what happens? Let's see what happens if I open this door.
So how do you sit with that space when someone comes in with something maybe very different from your value set or something you're just not familiar with?
I think it's easier when someone is talking about something that I'm not familiar with. Maybe they're from a culture or a country that I've never been to or heard much about. That I feel very at ease to say, please tell me more about this. I'm not familiar with this. Help me understand why this is a problem for you from your perspective. Most of the time, people are very happy to do that. And I feel like I've learned so much about different industries because all my clients have had different jobs. And as they talk about problems they have in their day to day life, they have to include explanations about what their job is in order for you to understand sometimes.
Mhm.
And I feel like I've learned a lot. I mean, I've had people working in, I don't know, every sector. And I feel like I've learned a lot because in order to see the world through their eyes, you have to learn who the characters are, what the pressures are, the skills needed for that position. So I feel like I've learned a lot. I think when someone is coming in with a really different set of values, especially if I find that value really repulsive, let's say, if I really don't agree with it and it's something visceral for me, that can be really challenging. I think that's where you really have to sit with yourself after a session and notice what buttons were being pushed. Um, Oftentimes, I find that as I get to know the individual's story and how they evolved as a human being, that belief makes sense. And as long as I can put the belief into context for them, then it's not a problem. I think and that is also where you really have to check your boundaries because sometimes people believe things, but they haven't really done their homework. They believe it because someone has told them to believe
Mhm.
it and not because they've done a thorough study. And so when you begin to question it, you realize they don't really know why they believe it. They just do. They feel like they believe it rather than to have an understanding. And that's where kind of staying on top of your own stuff and really understanding boundaries is so important because it's not my job to change their perspective. We might examine where you develop this belief system, particularly if it is contributing to misery or distress or dysfunction. Oftentimes it's not. And so having the boundaries to leave it alone, you're alone in the room with someone. No one else is going to hear it other than that person. If you challenge them on a political belief or a religious belief, and you really do have to check yourself. Where is that coming from for you? Is that just because that's a hot button for you? You've had an experience that makes you want to change that person's mind. Is that the scope of the work you're doing? Do you have somebody that you can get some supervision? A lot of times, these kinds of conversations, when someone comes in and says something that you find abhorrent, like sometimes it's just the people that are in your office. You're not going to believe what my patient just said to me. I remember I had a patient who made a comment about Jews. He was a guy I liked very much, successful older man. And he's like, said something about, well, the Jews, they'll always try to get a good deal, something like that. And um, I knew him well enough at that point to know he, in his mind, was not being racist. I think in his mind, he might actually have been paying Jewish people a compliment. Mm-hmm.
Mhm.
And it was something like that. It was an implication that Jewish people are cheap or something like that. And I definitely, had a flinch there inside. I I continued to treat him for a very long time. Um, and he didn't dwell on it. But I did think about it afterward. Is this something that I would need to confront? And I did sort of come to the conclusion that if it was something he continued to say, that I would address it, because I couldn't be dishonest that as a Jew, that I find what you're saying is offensive. I also knew that if I were to say something like that, it would be so hard for him to cope with, he would probably never come back. That was part of his stuff, attachment stuff for him. He had a very early life abandonment by his own mother. So, you can have a knee-jerk reaction to something offensive that someone says, but you have to bear in mind the entire context of the case, and your interventions, they have to be sensitive to the person that you're working with. And this was someone I was doing good work with. And we were working relationally many times through this childhood trauma he had.
I've had those come up too. It's like specifically that comment. I think people feel like it's a very innocent thing. Like it's just a fact that Jews are cheap, Jews are looking for a deal. They don't even think about it when they say it. And it's such like a punch in the gut, because you have to do everything that you just described in seconds.
Right. It has to happen really fast.
Yeah. Like, how am I going to handle this? Do I handle it now? What will happen if I do XYZ?
Right. Right. And you have, right. That's my issue to some degree, that I would want to, address that that what you just said was an epithet. But I knew this was a good person. I knew him really well. I'd worked with him for a really long time. And I also knew where he grew up and how he grew up and his age group and where he was from. And I knew a lot about his life experiences, and I knew a lot about his political orientation. And so that him saying that didn't totally surprise me when I stopped to think about it. But I had an initial emotional reaction. And, I think for younger clinicians, that's where there's so much to learn, because learning how to manage your own emotional reactions to things that clients say and stay on track and not start going down a road that is your own agenda, keeping it client focused. That requires, a lot of practice of being able to check in with yourself at the same time that you are delivering an intervention with a client. And that takes many years to learn how to do that. That's why I do think that learning a lot from in the beginning with manualized interventions, I think is so helpful, because it teaches you the language of how to explain a lot of these concepts to people the correct way. And then you move on from that. You start to utilize yourself, your whole nervous system, your whole body, the relationship. I mean, I always experienced psychotherapy as a very three-dimensional experience for me. I don't know how it is for you.
Say more about that. What does that mean to you?
When I'm working with someone, and I mean, sadly, I don't have cases that I'm working with directly right now, because I'm in a different position as co-founder and president at Galen Hope, but I oversee all the therapists and the clinical work here. And it's not that I never talk to a patient or a family, but I don't carry a caseload anymore. When I say that I experience psychotherapy as a three-dimensional experience, it's very visceral for me, that there is a piece of what's happening in the room that is not looping through my prefrontal cortex, which is planning the next step, that's picking the next intervention, that's like following those more academic steps that you take in a therapy session. There's a whole subcurrent of me checking in with myself and with the client in terms of nonverbal, in terms of the energy that's in the room, that I feel really in a three-dimensional kind of way. It's very, very visceral. It can be, there have been times where I've described sessions as feeling like I was wrestling an alligator. I feel it very, very deeply, even though if you were to look at it, it's just two people having a conversation, but it can go very deep.
I appreciate how you described that, because I think you also gave a really nice example of how therapy is not just talking to somebody else, but
Mm-hmm.
there's so many things that are happening, from literally the planning of what am I going to say next? Where am I going with this? To
Mm-hmm.
what am I feeling in my body? And how is that telling me something about the work we're doing too?
And so much for me. And again, I don't know. I think it's probably very similar to how actors work in many ways. There's the technique, and then there's the bringing it to life. And relying on your own intuition and your interactions with other people. For me, if you were to like press pause, if you could press pause in the middle of a therapy session and say, why did you ask that question right now? I don't know if at that moment I can always tell you, because I'm operating many times on so many levels, and one of which is that pre-verbal, like listening to myself. Someone could speak, let's say, for 3 minutes straight, telling me a story, and I might hone in on a detail that came up at 35 seconds in. And that's because I had a reaction. Something told me that was, and then after the session, I may be able to, usually after the session, yes, I can tell you exactly why, because I heard a word that I had heard that person use multiple times. I noticed a change. Like normally I can say that, a change in their facial coloring. I noticed that they started making less eye contact. I noticed that I started to get very tired, or I started to get very amped up, or I started to like obsess a little bit about something they said. So I could then go back, but it all happens so fast that something will say, go there, ask them about that. That's important. And so it may be that we had talked about that the week before, and I want them to notice it again. I just want to draw your attention that here we are talking about your sister, your boss, whoever, again. And I notice that you keep using this word to describe your experience, right? So if I'm noticing patterns that are coming up, so it just depends on, there's a piece of this of running it through your own mind, your own body. I feel like I run it through my entire body, what my patient says. Then, and then there's all the technique, there's all the history you have to keep in mind. There's your therapeutic goals and where you want to go. Long-term, short-term, in this session alone, all of that is in your mind at the same time. And it becomes more automatic. It's hard to talk about to someone who isn't there yet. But that when you're working with younger clinicians, I think that's a really important part of the supervision too, is to teach them, this is coming next for you. You're not quite there yet, but this is coming next. Yeah.
When did you start to feel more confident in that?
I would say, I mean, like if I'm going to be really honest,
Yeah.
really honest, I would say about 10 years in, where I really felt like I know what I'm doing. And being, clear on where my interests and my passions and my strengths lie, and where I might need to do some more work. I think in the beginning, and I'm sure this is true for everyone, that every case I got, I was like, I don't know how to do this. In my head, I was like, I don't know what to do. I didn't learn anything in graduate school.
I feel like I'm done.
Right. And people come to you with sometimes some very sensitive, very scary, very traumatic things. And they tell you all this in the first session, and you're like, you need to get a real therapist. I don't know what to do. That's where supervision was really helpful. And I did learn pretty quickly that was just part of my own stuff. I just learned that's how you react to basically every single client. That I just got anxious and I felt like I didn't know what to do. But then I made another appointment with them. They came back and I did know what to do. It was there. And you're not alone. I mean, your clients also are coming to you with a sense of what they need from the therapy and the relationship. And so that's always a great place to start. It doesn't mean there aren't other things to do, but it is a collaborative relationship. And if you make space for them to share with you why they're there, what they're looking for, that is extremely helpful in terms of planning your next steps. And that's one of the questions I always asked in a first session. I think every single therapy session, every new patient I ever saw, I asked them, what do you hope to get out of treatment? What are your goals? And so I wrote that down for every single client. And that is really nice, especially, 1 month in, 6 months in, to go back to what did we talk about, and are we meeting those goals? Sometimes I would even take it out. If a client is like, I'm not sure this is helping, I'm not sure that I'm really getting enough done. Well, let's go back and look at what you said in your first session.
Right.
And what you said you wanted to work on. And if we aren't doing that, then that's not good. But let's see, have we started to address this? Are you feeling better in this domain or not? So it has to be, I think, a very collaborative process in that way, and respecting that people do know themselves.
I find it so interesting too when you go back to the goals and you realize that's not what they actually wanted. And they're like, yeah, I think I need a different goal.
Mm-hmm. Mm-hmm. Right. I always thought it was interesting as a person who was an eating disorder specialist, and then people would say, I read your website, it really spoke to me. And then they come and they don't have an eating disorder.
Or they come and they want intentional weight loss. And that's all over my website that I don't do that. And I'm like, how did we end up here? Like, I'm so interested in how you chose me.
Right. It's not an accident that they chose you.
Right.
They just don't know that yet. Yeah. They chose you for a reason. Their subconscious chose you. Yeah. Yeah. Or I'm coming because of, my kids left home and I'm struggling with that transition of being an empty nester. So you chose an eating disorder clinician for that?
Right.
Oh, okay. And then, lo and behold, there it is. The issues with food.
This September, a first of its kind event is bringing together professionals who understand the intersection of eating disorders and Jewish identity. Introducing the inaugural JEDPRO Conference, the Jewish Eating Disorder Professionals Conference, happening virtually on September 5th. Join clinicians, dietitians, educators, and researchers from across the country for a day of insight, connection, and culture-informed care. Whether you're Jewish, work with Jewish clients, or want to deepen your understanding of faith and identity in eating disorder treatment, this conference is for you. With expert-led presentations, community discussions, and a shared mission to improve outcomes in the eating disorder care. This is more than a conference, it's a moment. Registration is now open at jewisheatingdisorderprofessionals.org.
Yeah.
And speaking of tracking, which we were talking about a little while ago, I noticed that you said your PhD was in health psychology.
Mm-hmm.
And this may be a personal bias of mine, but historically, sometimes those fields don't jive very well. You would think they do because it is fundamentally a health piece, but
yeah, that's a good point. When I started, I would say there was perhaps more of a bridge, because when I started in eating disorders, obesity medicine was like part of health psychology, and like the study of diets and like lifestyles and stuff. And at that time, when I started working in eating disorders, there still was more of that kind of fat phobic medicalization of weight than there is now. Not that it's not there, but it's definitely, there's much more conversation around it. Yeah. And and also, so also I started in the psycho-oncology. It was so far removed. It was just like a complete change of interest. I really love that world. And And I had at one time thought I wanted to like work in a hospital and see cancer patients, but there just weren't very many jobs to do that as a clinician. If you wanted to be a researcher, there were more opportunities. And I always had this real interest and passion in eating disorders. So I would say for me, where health psychology was helpful is that there's a lot of medical stuff that goes along with eating disorders.
Right.
And I had a lot of comfort with that because I had so much training in hospitals and with medical populations. And so, I worked in different units. I worked in a spinal cord injury unit. I worked in a nursing home. I worked with cardiology patients. I worked with cancer patients. So I had a very good working knowledge of a lot of like medical terminology and disease processes and medications. I was very comfortable with that. So for a population of people that experience a lot of medical issues due to the eating disorder, and when there's an intersection of the two, I think I have a better than average comfort level with the medical stuff. So to me, that was great. And I still got a full clinical psych training. And so, yeah, it was a little bit of a jump, but it was one of those things that I always wanted to figure out, how was I going to get into eating disorders? And then this opportunity presented itself at Renfrew. And that was my first experience. Yeah.
Renfrew was also my first job.
It was? Yeah. Which did you work at?
Philly.
Okay. So I was down here in Coral Gables.
Yeah, it was as a bachelor's in psych, and I was looking for something to work with during my master's. There was nothing. And I had not wanted to work with eating disorders. And I got this job at Renfrew, and now here we are almost 20 years later as an eating disorder specialist, and I wouldn't want to do anything else.
Yeah, and I think that all these eating disorder programs are a great breeding ground for the future clinicians, because they do provide an opportunity for people to work at least in that kind of a setting without having a master's degree or a doctorate degree. Like, you can go get a job at a treatment center and work as a tech and get some real world.
There aren't many places to do that.
No, not at all. Yeah, I agree. So it's a valuable, at Galen Hope, we employ kids out of college and people getting their masters. So it's a great place.
It was eye-opening.
It's a lot to take on, though. I think sometimes like, wow, without any kind of clinical training or supervision, that must have been hard because the patients get upset.
Yes. Oh, yes.
Yeah.
And talk about that feeling of, I'm doing it wrong every session. And that was, I think things have changed a lot. My understanding now is they offer a lot more training than when I started. It was very much like sink or swim. You started and you figured it out, or you quit.
Yeah. We always say here, it's the hardest job at Galen Hope. Even though we do give them training, it's still, they're on the floor every day, supporting meals, flushing toilets.
It's a challenge. Yeah. That's my favorite part, right? Everyone's favorite part.
Yeah.
That was so weird to me. I'm like, you mean I have to sit there while they're using the bathroom? Like, what? No one trained me. No one told me in college that this was going to be my job.
Let me tell you something. Even as a postdoc, I flush toilets. So you have to, if you're going to do the work, you have to go all the way. You have to be willing to do it. And you have to know what that experience is like.
I agree.
To flush someone's toilet and to also bear the consequences of what that feels like for them, of how you do that. And then they have to have a conversation with you after you just flush their toilet.
And for those who are not eating disorder providers, what are we talking about?
Right. What are we talking about? That people who are in treatment for eating disorders at higher levels of care, a lot of eating disorder behavior can happen behind closed doors in the bathroom. And so to ensure that they are not engaging in behavior such as purging, they are not permitted to flush their toilets, and a member of the staff has to do it for them.
Yep. We also had to sit with our foot in the door just so that they weren't behind the closed door. And it was such a weird bonding moment at times, because you have clients who are very uncomfortable, as I think anyone would be, who are singing songs
Yeah.
telling me about their life story while they're pooping. And I'm like,
Yeah.
this is a job.
Yeah. I mean, and then you also do meal support, right? You sit with them at a meal.
Yeah.
And you have to make conversation with them and at the same time catch behaviors, enforce rules, ask them to complete a meal. I mean, again, these are things that you never learn about in graduate school.
They didn't even touch on these things as possibilities.
About how boundaries can be flexed in ways that are not inappropriate, right? Like, I think by and large, we would have learned in grad school that all of what we just described is inappropriate.
Absolutely. Like that is a dual relationship. It's a boundary violation. You're going to therapist hell.
Right. Yeah. And if you work in a milieu treatment setting, you have to learn to slide those boundaries. And as a person who's done a lot of clinical supervision, I mean, I have supervised literally more people than I can count. I mean, I think I'm probably close to 100 people that I've supervised over the course of my career. And every once in a while, I did find individuals who could not successfully slide those boundaries in a way that worked for the clients or worked for them. Did you ever see that in any of the settings you worked in?
Yes, they were either too rigid or too flex and couldn't find that middle ground.
Right. Over disclose, or they got dysregulated themselves.
Yes.
Mm-hmm. I found that it could get disorienting for them too. That they would sometimes am I friends with the clients? Am I not? What should I disclose? Like when you're sitting at a meal, you can't have the same boundaries you would have that you would have in a psychotherapy session. I think at the end of the day, I mean, for me, what it always comes down to is in any setting, a client needs to feel there is a human being in the room, not someone formally, observing them and writing notes, a person. Yes, you may have knowledge and skills that they don't, but they need to connect with a real person. And so if you're maintaining these rigid boundaries and you're sitting with someone having dinner and you can't talk about a movie you saw or a song you like that's not going to feel like a real person. And so, how do you flex those boundaries in a way that still preserves the relationship, preserves your privacy, and where it's very easy for people to slip into going too far?
And I was taught in my program, you never talk about yourself. And if you're going to, you need to have this incredibly in-depth conversation about why they want that information. How will it hurt them to know or not know? And sometimes that's valuable. And sometimes they just want to know if you went to a movie this weekend.
Right. I had a patient once who said to me, I like your shoes. I said, oh, thanks. She goes, where'd you get them? I said, I don't know where I got them. Nordstrom. I think I got them at Nordstrom. Oh, I like them. And she goes, I had another therapist who I said to her, I like your shoes. And it was like, why did you say that? What does that mean? And she's like, I just really liked your shoes.
And that's exactly how I was taught to handle even the I like your shoes conversations.
But I think, there's no hard and fast rule. In some cases, they just like your shoes. In some cases, they are, it's an attachment issue. It is a boundary violation. They're testing the waters to see, I start with your shoes and what's next. So that's where listening to yourself and, having a good conceptualization of the case, there may be certain cases that come in that you have to have firmer boundaries. But even if that person is a boundary pusher and they say, I like your shoes, you can still be a human being. Thank you. You don't have to get into the rest. Thank you very much. I appreciate that. You can still have a boundary, even and be a person.
So we've kind of hedged into this area of like what we've learned in the past and how those things have changed. So is there a moment or are there things that you're like, yeah, I do this completely differently now and I wouldn't do it the way that I was taught or I wouldn't do it the way I did it 20 years ago?
Yeah, for me, what comes to mind is borderline.
Mm-hmm.
What I was literally told in grad school was people with borderline never get better.
I've heard that.
And right. And it was a rule out for our training clinic. And, which really was a disservice, I think. because when I got into private practice, people with that diagnosis wound up in my practice. We were also told never tell them that they have borderline.
Right.
And
or very discreetly because of how they would react.
right. Well, and of course, I mean, when you go in with that attitude that it's pejorative and it's a damning life sentence, yeah, they're going to have a bad reaction to it. So, I remember many years ago, I had a client who was a student at University of Miami, where my office was very close to there, and I had to send her home because she was not safe to stay in Miami. And I was like, I think this kid is borderline. And this had to be close to 22, 23 years ago. And it was, I mean, I had the internet and I looked up DBT, New York, where she was from. And I found someone in New York and I connected her. I was like, I just know that this therapy is for people with borderline. I had not been trained in it. And there was almost no one at that time who did it. It wasn't like now where it was all over the place. There were a handful of early adopters that really understood it well and were doing it. And I just said to her, you have to go to this person. She's the only person. I didn't even know if it was like close to where she lived. I just like, you just need to go to this person. I found her. And then like, I'm going to say like 6 or 8 years later, she wrote to me and she's like, you know, with just a lot of gratitude about just how life-saving that was for her.
I love that.
And, you know, I treated her for a while, but then it became completely unsafe for me to do so. I had no idea what I was dealing with. But what she got from me was there was a person in the room who cared and who kept her safe. And her parents, they were from a totally different culture. They did not understand how severe this was. And I was like, and finally I was just like, you need to come here and pack her up and take her home. And they did. To their credit, they did. But it turned out to be a great thing for her, and she's doing great in life now. And, but that, I feel like in retrospect, that was a real disservice, for me, because I had to learn on my own what borderline really was. And I think we've come such a long way in our understanding of it too. I mean, beyond DBT obviously was a humongous contribution and a change in the way we approach borderline. But in terms of giving people hope that this can get better and you can live with it, and that it's something that can be worked on in therapy. I mean, basically I was told either just stop seeing them or ignore it. Like, it's never going to get better. There was no framework really to work with them in mind. The other thing that I think really changed for me was I was sort of at the end of that first wave of cognitive behavioral therapy.
Okay.
And so what I had always learned was that psychoanalytic therapy is BS. That's what we were taught in school. That it's BS, that it's totally invalid, that there's no science behind it at all. And when I went into this office with Roy and Elliot Ehrlichman, who were psychoanalysts, what I really saw was we're all talking about the same stuff. We just have a different framework or different vocabulary. But when you're working with people, ultimately, it's all the same thing. You may gravitate towards one orientation over another because that may fit with your personality, that may fit with your training. But ultimately, if you're going to see people in a long-term kind of way, you deal with the relationship, the relational issues, and you can frame those things, you know, in a lot of different terms. You can use different language to get there. But at the end of the day, you're talking about people's history, how it's playing out now, helping them correct beliefs and thinking that they adopted as a result of these experiences that they had throughout the course of their life. You can do that with psychoanalytic techniques through the relationship and through, you know, the client projecting this onto you and all that stuff. Or you can do it, you know, looking at thoughts and feelings and things, but teaching them coping skills. But eventually you kind of it all winds up in the same place. So
Right.
I feel that probably the way I was trained created a certain hostility. Maybe hostility is a strong word, but being a resistance, a lack of openness to certain techniques. And I think the more you practice, the more you notice that you just constantly need more skills. There's more to learn.
I think that's pretty common for folks who've been trained more psychodynamically. There's like a poo-pooing of manualized treatment. And for
Mm-hmm.
folks who have a more manualized treatment background, it's like, oh, that's all just bullshit. Like we don't do
Right.
that stuff.
Yeah, and I'm just very wary of anybody who's very dogmatic in any singular modality, and you see it all over the place. And it's not
Yes.
that DBT isn't helpful and isn't great, but so is lots of other stuff. I've done somatic experiencing training. I've seen people get very, very deep into that as if that is the only way to help someone. Or DBT is the only way to help someone. And for certain people, that it may be the only way. But most people are multidimensional, and different techniques may work at different points in the trajectory of their life or in the trajectory of their treatment. And so having lots of different tools in your toolkit is really, I think that's the way to go. I just think that getting yourself rigidly adhering to one methodology, you're going to miss certain things that could be really helpful to your clients and shut them down.
There's a very like cult-like atmosphere to some of these modalities and trainings, and it's a turnoff too, because I know, at least for me, like I conceptualize most clients through an IPT, interpersonal process therapy framework. That's just how I think about what is bringing them in and going on. Therapy for me looks very integrative. Like we're pulling from all over the place because it's what helps.
Right. And so sometimes you might use a more psychoeducational intervention. Sometimes you might do something more experiential or relational. So I think having that flexibility, and that takes time to be able to slide in and out of different techniques, for sure. And it doesn't mean that you still aren't using that framework too.
I think that's what gets lost. Like being eclectic or integrative isn't necessarily a bad thing, but you have to start from somewhere. And I think that's the piece that sometimes people get lost with. They don't know where they're starting from. They don't know how they're conceptualizing, and then they're all over the place.
Yeah, I think that, I certainly have worked with young clinicians who really don't even understand what you mean when you ask them, how are you conceptualizing this case?
Yes.
They don't know how to do that. And that's a real disservice that their practicum placements are doing and their programs are doing, because I always say you have to have a diagnosis before you can create a treatment plan. So, how are you thinking about these behaviors, these symptoms? What purpose are they serving? That's a very hard thing for some new clinicians to do. And I would say if someone's listening to this and you don't know how to conceptualize a case, if you don't know what Joy and I mean when we say that, you need to get yourself a supervisor so that you learn how to do that, because that maps out the rest of the treatment. And for me, and I'm sure you feel the same way, there is a bit of a process of experimentation. Was the way I'm thinking about this right? There's you have hypotheses around what function a certain behavior serves or what something may mean. And then you have to test it out. You try out different interventions, and based on how your client responds, it either proves or disproves that hypothesis. So that's also, I think, an interesting way in which the research background that I had in my PhD program plays out in a micro level every day.
Yes. And I think that's lost a lot. I know when, again, in my training, it was therapy as a science and an art, and you have to have the scientific foundational knowledge to be able to practice the art in a meaningful way.
Right.
And I feel like some of that has been lost a little bit, and I'm not sure when it changed. But I know sometimes even when I interview new employees and I ask just out of pure curiosity, do you have a theoretical framework or model that you practice from? I'm getting like blinking stares back.
Yes.
And
Yeah.
I'm wondering when we lost a little bit of that.
Well, and it's interesting to me how often people cannot answer that question. We interview a lot of people at Galen Hope,
Yeah.
and if they are interviewed by me, they will get that question. And it's not meant to be a gotcha question. It's meant to be a
Not at
starting,
all.
right?
Yes.
Like, it's exciting to me. I want to hear what you're into and what you've studied and what you like. And it's very common for people to not know that. And I think it's interesting that they don't know what the orientation is of the school that they've attended.
Right.
Yeah.
That at the very least, like because our schools all push something. Like, what did your
Mhm.
school push
Yeah.
as the model for therapy?
Yeah. When I went to grad school, I was there at a very interesting time. So they had like the older faculty that were retiring and the younger faculty that were coming in with the evidence-based treatment, CBT kind of stuff. So I was able to get supervision from both. So I had some of the old guard who did more psychodynamic stuff. And then I had the younger professors who were doing the more evidence-based stuff. And then all the research we were doing, I worked on clinical research. So I got to do the manualized interventions in the context of clinical studies.
You got
So
everything.
so I got a lot of really different experiences. And then I worked in hospitals and I worked in clinics. And so I really got a nice wide range of experiences. Um, I can't speak to why students are coming out not being able to answer that. And it's not true for everybody.
No,
So,
that's an exaggeration, but
yeah.
I'm seeing more of it.
Yeah. And I don't know. I do think that there's a lot of like social media influencers who boil down psychological science into these little digestible bites. And I think many of them are doing it with the intention of being helpful to people, but I also think they're doing it with the intention of promoting themselves.
Of course.
And I wonder if that's also, it's like a diluted version of what psychotherapy really is. And I wonder if there's just that's so much part of the business model now of establishing a
Yeah.
new business that I have to be out there, right? So they have to come up with little, like some sort of little area that they're going to be the person who speaks to that issue, the expert on that. Yeah. I don't know. But I if a lot of what you're doing is focused on getting people's attention publicly, I feel like psychotherapy is such a private experience. It
And
requires a lot of work on yourself too.
it's challenging because I love that people are getting more exposure
Mm-hmm.
and the frustration of exactly what you're talking about. Like, I'll have clients come in and say, I heard on TikTok that if you do this, you're autistic, and I do this. So therefore, I'm like, maybe. And it's so much more complicated than that.
Right. And there's like actually a formal process that people go through to get diagnosed with autism. And we can
Right.
do that, right? We're not going to diagnose it on TikTok. Yeah, I
Right.
mean, they certainly, like, I've seen some really interesting TikToks about like toxic narcissists. I think that can be really validating to people too.
Yes. But I also think narcissism is getting thrown around way too much. And anytime somebody engages in a less desirable behavior, they're being labeled as a narcissist now.
Oh, wait, yeah.
Right.
Yeah. So yeah, and also I think watching a TikTok video for 30 seconds, it's entertaining, it's interesting, it's put together in a way that's meant to be that way. And then people come to therapy and it's slow.
And it's not entertaining and it's not fast.
No, and it's painful at times.
Yes.
And um and so it may be creating, I don't know, maybe some false expectations of what actually happens in therapy.
Perhaps. Yeah. And I love social media. I utilize it all the time. I market myself and my business that way too. But I mean, hence the name of the podcast, right? Like it depends on how
Right.
it's being used and in which way it's being consumed and what you're taking away from it.
Right. But I do think people who are searching for answers wind up on social media.
Yeah.
Right. Yeah. And, you don't know what they're watching. And once the algorithm picks up on that, on their interests, they get more and more and more. Right. So, and that's not a replacement for a real evaluation.
Not at all. There's a lot missing. And in
Mhm.
fact, I even have some clients who come in and we do a social media purge because the algorithm has taken you in a place that is
Mm.
not healthy.
Yes. Yes. That's really interesting. So yeah, I think our field has a lot to grapple with in terms of the influence of social media and the way clinicians portray themselves on social media and the ethics around that.
There is
That
some wild stuff out there right now.
I'm going to have to start looking.
I saw once she marketed herself as a licensed clinician. I did not look up her license. I don't know. She was advertising therapy services, and I am not overstating it when her picture was basically her in lingerie. And
Mm.
I was like, this is very interesting.
Yeah.
I'm so curious as to how we got to this picture because it was very clearly inappropriate, but practicing as a licensed therapist, assumedly.
Yeah. Well, as a person who's done a lot of supervision, that like I feel bad for that person that they didn't have good role models and they
Yes.
didn't have someone really working. I mean, the supervisory relationship is more than just signing notes.
Should be.
It's, you're really helping develop that person as a professional and and teaching them about this community of clinicians we live in and what the norms and expectations are. Many years ago, and I was not only supervising a bunch of clinicians, I also was supervising a program. And we had a practicum student who kept knocking on our door saying she wanted to do a practicum with us. And finally I said, you know what, this kid's showing a lot of kind of initiative. Let's give her a shot. So we gave her a shot, and she was problematic. She was a lot of work for the employees. She didn't seem to grow and be able to function independently. We asked her to not come back for the second semester. We felt that we just didn't feel
a big deal.
Yeah. She was just not the level of the work was expected, and she was just a lot of work for the other employees. So she went and got a position somewhere else, and she wound up having sex with a patient at that facility. And and I heard this through somebody who was planning to hire her, and then that facility called him, and then he told me, and blah blah blah. Anyway, so I said to all of my trainees, I said, in case no one has ever said this to you, let me make this abundantly clear. Never have sex with a patient. Never. Never have sex with a patient. If you never have sex with a patient, I can almost guarantee you will go through your entire career without a problem.
I had my ethics professor in doctor college, Dr. Davis, who's wonderful. He started ethics on the first day with "Don't fuck your clients."
Yeah.
And I'm like, got it. And now
Yeah.
I teach undergrad ethics. And I'm like, I shouldn't have to say this. However, people are coming at all different places, and we get into this field with all different experiences. So same thing, in case no one has ever said it to you, do not fuck your clients.
Right. Like there's lots of other people to do that with.
Right.
Just don't do it with your client.
And anyone else. Like go on Tinder, do whatever you need to do, just not with your clients.
Yeah. Like just if you do that, you're probably good to go. Well, if you like the show Shrinking, which I happen to really enjoy, it's a funny show, but it like the boundary violations and like if you don't have strong role models and mentors, you might think these kind of boundaries are okay. Yeah.
Yeah.
Your patients can live with you and you can date them.
And I think that's part of why I think it's funny, because we're seeing the boundary violations and we're like, oh my gosh, like this is hilarious. But exactly to your point, if you don't know any better, it becomes a normative experience because this is our view of therapists in TV because that's what sells.
Yeah. Yeah. So, so hopefully if there are some young clinicians listening to this and they are newly licensed, please make sure you have a mentor in your life. I did supervision for at least like regular supervision for at least 10 years after I got my license.
It was on and off. And then this year I started learning some new skills and decided that I wanted a supervisor again. And it
Yeah.
is,
Anytime I did a new training, so all the
yes.
supervision came with that. But like the regular day-to-day supervision, like I was still in grad school, I did that for 10 years.
Oh, I love that. I wish I could have afforded that
Well,
prior.
and I also had supervision groups. I was in a supervisory group. And then I had, the guys in my office, Roy and Elliot, that I got supervision from once a week. We had lunch together and would discuss cases.
So I had fantastic mentors. I think it was never formal, but really some amazing people that provided that supervision and consultation.
It's all the trainings, all the supervision, it's an investment in yourself. And I mean, I think about all the years of study and training that have gotten me to where I am now. And the way I deliver care is all a direct result of all those experiences I have. They all mold and shape and they make a contribution, and you start moving in a different direction, then you learn something else and you add that, and it all gets incorporated into, your personality. And so it's such a worthwhile investment. And
Absolutely.
The ethics piece of that too, of just keeping on top of yourself and making sure that you're keeping the relationships with your patients healthy, that you're staying on top of any biases that might come up. It's just so important. If you really are wanting to help people, getting supervision and investing in yourself is just an essential piece of that.
That's another thing I've noticed too. And I don't want this to turn into just like shitting on other clinicians, but I've noticed this, like not going to conferences, doing all like self-paced continuing eds, isolating in the community. And I don't think it's purposeful. And I am a completely virtual therapist myself, and I see how easy it is to become isolated, and that lack of engagement in like the continued development piece. And that has always been very interesting to me too.
Well, I will say, I always preferred going in person, because to something like, even it's just one of those like 6-hour ones that comes locally to wherever you live, because I would always meet somebody that would become a new referral source. I don't think I ever went to any kind of CEU or conference where I didn't meet someone and then they started referring to me. That is how you meet the other people that are working in your community, and they find out that you're there. So
I love conferences. You learn so much. But I think the most valuable part for me is the networking that takes place at the conferences.
For sure. For sure. And you might go to a workshop by somebody who you think is really great, and then you could get supervision from them, and you maybe never, or they introduce you to a new type of therapy, and then you go and get trained in that. So that's the only way that you're going to get exposed to new things and things that you never thought you'd do. I remember one time I went to a conference, and I walked into an experiential workshop. It was like a psychodrama one or something. I wanted to die. I was so uncomfortable, but it was so instructive to me around how I lived in my head. Yes. I relied so heavily on my intellect to deliver care. And so that was a really important experience for me to see that.
I have learned so much from those experiential pieces and topics that I never thought I would be interested in. And then I happened to dip into that session, and I'm like, oh, this is fascinating.
That's what I usually look for. And when I go to a conference is what do I know nothing about? Like if it has a term in it that I've never heard of, I'm like, I'm going to that one.
Yep. those are the most fun. Like you
Yeah.
get just exposed to all these new wonderful things,
Yeah.
even if you disagree.
Yeah. Yeah. And you just cross your fingers it's a good presenter. But yeah, I think that whatever your area of specialty is, going to the national conferences, going to local and regional trainings, that's how you're going to start to make colleagues. And that's how things begin for people. Maybe you then develop your own training or something. You just never know where these are the doors that get opened by interacting with people in your profession. And I think in many ways, going to conferences, particularly conferences more than like CEU trainings, but particularly conferences is an area that you have some experience in. It's also a way of checking to make sure, am I doing things in a way that's similar
Yes.
to the other people who do this? Are they encountering similar issues? Are they approaching it? Am I thinking about it the right way? Or am I short on certain skills or knowledge? So I think it's a really good like quality assurance check on yourself to make sure that
Absolutely.
you are keeping up with whatever the field is talking about. And that if there's a change in the way people think about, I mean, the eating disorder space, for example, there's always a lot of change. They embrace change very
Rapid
readily.
change. Yeah.
Yeah. In terms of terminologies that's used, and this is out now for this reason. We don't say that anymore. And so, yeah, especially someone who's a little past mid-career, it's easy to say, well, I've kind of seen it all. I don't need to go to conferences, but you have to stay current.
I think that's probably what worries me the most when I work with new clinicians or very seasoned clinicians. And I'm hearing like I don't engage with the community. Like, ooh, okay. So how are you learning still?
Yeah, that's always really frustrating to me. I will say I feel like I saw that more, but when you see therapists, psychologists who are in their 60s and 70s, and they're like, "Yeah, I don't do that stuff anymore. I'm good." And I'm like, "Oh,
Yeah,
I hope I don't do that."
me too. Because I know even now I turned 40 this year, and I still, first of all, I'm still like, who gave me permission to work with people's lives? Because that's terrifying. And there's so much to learn still.
So much. I mean, that's what I love about. I love that I love this field. I love that I find it endlessly interesting and exciting, and that even in my time off, I like to read about it. I like to watch stuff about it. I like to go to classes. I love that. I still love it. I still find it so interesting.
And
I,
you've had a transition because you're not doing direct patient care anymore. You're more
I
admin. So what has that shift been like for you?
well, it's been I mean, there's times where I do miss it, and sometimes I'm like, well, can I take a patient or two? I can't. I think that recognizing that the amount of work that I have to do running a treatment center occupies so much space that I can't take care of people like that anymore right now. I can't. I mean, I can have a single conversation with somebody, but
Of
I
course.
can't I can't take them on in a long-term kind of way. I'm not available and I don't have the emotional space for it. So, um I think that is but again, that's part of all the work and training and supervision that I got of recognizing what good care requires from me. And I know I can't
Mhm.
deliver good care to an individual client right now. I do on a macro level. I'm, obviously
Yes.
supervising the team and helping them, but that comes from the work I've done on myself and done with mentors of recognizing that. I fought it, but I recognize it's not doable.
To do
Yeah.
this work well, you have to know yourself in a way that is thorough and quite daunting at times.
And believe me, the thought comes up, could I take a few patients? Because I miss it. Could I take
Mhm.
just a few? I mean, that thought comes up frequently for me. And it always comes back to that's not,
Right.
they wouldn't be
You're
getting,
doing
I
really,
don't want to
really
phone it.
important work. Yeah.
Yeah. I don't want to phone it in for someone.
Is there anything that you didn't get a chance to talk about that you wish you had?
We covered a lot of ground. No, I think we talked about everything. This was so fun. I love talking about this.
I
And
loved hearing you.
yeah, it's, to talk about like what goes on in the mind of a therapist and how we develop ourselves as clinicians. I don't think there's enough conversations about that.
I agree. Like I mentioned before we started recording, that was really kind of where the impetus for this came from. I have developed through conferences and networking throughout the years this beautiful network of people who have so much experience and so much skill. And it sparked this interest of, well, how did you get here, and what are you still learning, and what do you want the new people to get as they start their journees and careers?
Yeah. Yeah. Well, thank you for doing this. I can't
Thank
wait
you
to see
for
how it
thank you
comes
for
out.
being the first guest. I mean, with
Yeah,
brave
thank
soul.
you. So we'll have to come back in like a year and see what you've learned in a year after talking to all these therapists.
That'll
I'll
be
interview
the
you.
anniversary
Yeah.
podcast, like the
Yeah.
takeaways.
Yeah. Yeah.
Um, so one last question.
Sure.
If you had one piece of wisdom, like a little shorty pearl to give to people, what is that for you?
To clinicians,
Yeah.
a pearl to give to clinicians. One thing that I was taught in terms of the self-care, this was something that I learned to do, and it was from my mentor, was that I always had to have things I was looking forward to. So whether it was like a little weekend vacation or a training I was looking forward to, things that fed me. Maybe it was I don't know, an event with friends or something, but I always had to have stuff planned a little bit ahead in the future that would force me to take a break, force me to do something that fed my soul. Yes, the daily self-care, the exercise, the whatever, getting enough sleep, whatever, like, yes, that's part of it. But I needed more than just that kind of stuff. I needed little things to look forward to throughout the year that kind of kept me going, and that refocused me also on my own life.
Yeah. So something that brought joy and passion to your life that you had continuously scheduled that you could look forward to.
Yes. Yeah.
I love that.
Yeah. So that was how I always had a little trip or something that, and it didn't have to be anything, huge, but just things
Right.
that I was looking forward to that, and that was how I made sure that I took breaks, slowed down, kind of thing. Yeah. So that I guess I would say that.
Thank you so much. I've so
Thank
very
you.
much enjoyed our time together.
Oh, this was great. Thank you. Thank you for doing this. So we're going to reconnect at 1 year.
Yes. Yeah. We'll
Okay.
have to, like oh my gosh, reality TV. We'll have to have a reunion. Everybody.
Yes, that's right.
Yeah. How's it change?
Right. Yeah. So, well, thank you for inviting me to do this. And then we'll reconnect in a year, see what you learned.
I love it.
Okay.